Hello everybody and welcome to our module on metabolic acidosis. In the video on acid-base principles, I talked about the 4 types of acid-base disorders, and in this video we're going to focus on the 4th one, metabolic acidosis. Metabolic acidoses are the most complex set of acid-base disorders, and the reason for this is that there are just a lot of potential causes of a metabolic acidosis. In all of these conditions, there's a reduced pH, meaning there's an acidosis. There's also a reduced bicarb, meaning it's a metabolic acidosis. And then finally, in any metabolic acidosis, the first thing you need to do to figure out the cause is calculate something called the anion gap, which we'll talk about in a minute. At the bottom of this slide, I've bolded the key features of a metabolic acidosis. The pH is going to be less than 7.37. That's below the normal range, and the bicarb will be reduced. And if you look at the Henderson-Hasselbalch equation at the bottom of the screen, in all of the metabolic acidosis disorders, the bicarbonate level is reduced. That's the primary abnormality. This causes the pH to fall, and then the compensation by the lungs is to decrease the PCO2. In order to do this, the respiratory rate will increase and there will be hyperventilation. That's the normal physiologic response to a metabolic acidosis. So now let's talk about the anion gap. Sodium is the major cation in the serum, meaning it's the major positively charged molecule that you find in plasma, and it is balanced by anions, which are negatively charged molecules like chloride and bicarbonate. All positive charges in the plasma are balanced by negative charges. The plasma does not have a net charge of either a positive or negative value. So if you look at the bottom of the screen here, in human plasma you find sodium of a certain level, like I've indicated here in red. It's balanced by chloride and bicarbonate and then by a bunch of other things, and those other things are what makes up the anion gap. These are things we don't usually measure on standard measurements, things like negatively charged proteins and phosphates and sulfates. So because we don't routinely measure these things, but we do routinely measure sodium and bicarbonate and chloride, we can easily calculate an anion gap by taking the sodium and subtracting the chloride and bicarb. That will give us a value for the anion gap, and that value is very helpful in determining the cause of a metabolic acidosis. So the anion gap, as I told you before, is the serum sodium minus the chloride plus the bicarbonate. And a normal value for the anion gap is about 8 to 12. It varies a little bit depending on which laboratory you're talking about and which reference you refer to. So once you determine that a patient has a metabolic acidosis, you can then subdivide it into an acidosis associated with a normal anion gap or with an increased anion gap. And these two types of disorders have very different causes. So for example, let's look at the numbers on the screen here. Imagine a patient has a serum sodium of 140, chloride of 103, and a bicarbonate of 26. Then the anion gap is going to be 140 minus 103 plus 26, which is 11. And this is a normal anion gap. And therefore, if this patient had a metabolic acidosis, we would think of the causes of metabolic acidosis associated with a normal anion gap. Let's talk briefly about why the anion gap matters. There are basically 2 ways that you can develop a metabolic acidosis. The first way is if you are losing bicarbonate. If the primary mechanism of your metabolic acidosis is the loss of bicarbonate, then you're going to have a normal anion gap. The reason for that is that when the bicarbonate level falls, the body compensates by retaining chloride so that the total amount of negatively charged substances remains constant. So since the anion gap is sodium minus chloride plus bicarbonate, if your bicarbonate goes down but your chloride goes up, then the anion gap will stay normal. And I've shown this in an illustration on the screen here. On the left is someone who is normal with a small anion gap. On the right side of the screen is someone who has a non-anion gap acidosis. Their bicarb amount in the plasma has shrunk, but their chloride has increased, and the amount that is in the anion gap remains unchanged. The second way you can get a metabolic acidosis is if you are retaining an acid, for example, keto acids in a patient with diabetes or lactic acid in a patient with hypoxia. When these things happen, the bicarbonate still falls, meaning you still get a metabolic acidosis. However, the chloride does not go up. That's because these types of acids have their own anions associated with them, and that anion compensates for the fall in bicarbonate. As a result, there's no change in chloride, so the anion gap increases because the anion gap is sodium minus chloride plus bicarb. If the bicarb goes down and the chloride doesn't change, then the anion gap is going to increase. So let's look at some pictures again on the screen. On the left is a normal patient. On the right is a patient with an increased anion gap metabolic acidosis. So what's happened is the amount of bicarb has shrunk, as you can see, but the chloride level is unchanged. Now we still have a balance of positive and negative charges, but the balance is no longer being made just by these substances that make up the normal anion gap. It is also being made up of negatively charged anions associated with the acid that is causing the acid-base disturbance. So as a result, in this situation, you have an increase in the anion gap. Let me briefly mention hyperchloremia, which I just touched upon. An increased serum chloride is seen in all non-anion gap metabolic acidoses. In fact, these type of acidoses are sometimes called hyperchloremic metabolic acidosis disorders. Once again, this is because the negatively charged bicarbonate level decreases. There's no acid-related anion associated with the disorder, therefore chloride rises to compensate for the lost negative charge. So always remember this for board questions about non-anion gap metabolic acidoses. They're all going to be associated with an increased chloride level. So just to make this very clear, let's go through two cases. In the first case, the patient has a pH of 7.31. This is low, so there's an acidosis present. The bicarbonate level is low, so it's a metabolic acidosis. And then if the sodium is 134 and the chloride is 108, the anion gap is 10, which is normal. So this patient has a non-anion gap metabolic acidosis. Second case, the pH is also low at 7.27 and the bicarb is also low, so it's a metabolic acidosis. In this case, however, the sodium is 132 and the chloride is 93, and this works out to an anion gap of 28, which is increased. So this patient on the bottom, even though they have a similar pH and a fall in bicarb, has a very different type of disorder. This patient has an anion gap metabolic acidosis. Let's start by talking about the non-anion gap metabolic acidoses. Far and away, the most common cause of this problem is diarrhea. If you see someone in the hospital and they have a non-anion gap metabolic acidosis, they almost always have a diarrheal illness. Usually that's also associated with hypokalemia because you lose potassium in your stool when you have diarrhea. So a patient with a non-anion gap acidosis and hypokalemia is almost always going to have diarrhea. Second most common cause of non-anion gap metabolic acidosis that you'll see is saline infusion. When you infuse sodium chloride into a patient in the hospital, that sodium chloride contains lots of chloride ions. This causes a problem that's referred to as chloride toxicity. Chloride is negatively charged and it drives negatively charged bicarbonate from the plasma, and therefore anyone receiving sodium chloride, especially if you give them a lot of it, is going to develop a non-anion gap metabolic acidosis. And so clinically, in terms of real life, diarrhea and saline infusion are the most common reasons you will see a non-gap metabolic acidosis. Much more rare than either of these two things are the renal tubular acidoses, which I talk about in another video. These are problems with the renal tubules in the nephron that lead to an acidosis. They're very rare, much less common than diarrhea and saline infusion. And then on this slide, I've listed some other even more rare causes of non-anion gap metabolic acidosis. One is hyperalimentation. So patients who are unable to take in nutrition orally are often given intravenous nutrition. This is called hyperalimentation. And many of the amino acids in that nutrition are acidic, and so depending on the makeup of the hyperalimentation, this can lower the serum pH and cause a non-gap acidosis. Acetazolamide is a carbonic anhydrase inhibitor. I talk about this drug in the video on diuretics. It blocks formation and resorption of bicarbonate, so it will cause a non-gap acidosis, and that's by design. This drug is often given to people who have an alkalosis, and it's given on purpose to cause an acidosis. And then finally, if aldosterone is not working in your body for some reason, either because you're on a drug that blocks its effects like spironolactone, or maybe if you have Addison's disease, so you're not releasing aldosterone from the adrenal glands, this will lead to the inability to excrete protons effectively, and the body will retain protons, causing an acidosis. Remember that the job of aldosterone is to promote the excretion of acid in the urine. So if aldosterone effects are missing, that will cause a non-gap acidosis. So now let's talk about anion gap metabolic acidosis disorders. And for years and years, students have memorized the causes of anion gap metabolic acidoses by the mnemonic MUD piles. MUD piles stands for all these words shown on the screen here, and in the next few slides, we'll go through them one at a time to talk about why they cause an anion gap metabolic acidosis. Let's start with methanol. Methanol is found in antifreeze. It's also found in industrial cleaners and windshield wiper fluid. And in the body, it's metabolized to formic acid. If you look at the bottom of the screen, methanol is metabolized by alcohol dehydrogenase to formaldehyde, and then by aldehyde dehydrogenase to formic acid. These are enzymes that normally metabolize ethanol, but they can also metabolize methanol, and then methanol will form formic acid. Formic acid will drive down the pH, and it will be an anion gap metabolic acidosis because the anion in formic acid will increase the anion gap. Methanol is a central nervous system poison, and one of its key effects is vision loss, and there's usually going to be vision problems described in a patient who has consumed methanol. In addition, it can lead to coma. So the classic case of a patient with methanol poisoning is going to be someone with suspected ingestion. Maybe it was an accident. Maybe the patient was trying to commit suicide. Sometimes alcoholics consume methanol, hoping that it will have an alcoholic effect on the body. The patient will often be confused. They may appear to be inebriated. They will complain of visual symptoms almost always in a board question about methanol, and there will be an increased anion gap metabolic acidosis present. The treatment is to inhibit alcohol dehydrogenase so that methanol stops being metabolized to formic acid. There are two ways to do this. One is a medication called fomepizole. It also goes by the name Antizol. It inhibits alcohol dehydrogenase. And the second treatment is ethanol. Ethanol, which you can find in alcoholic beverages, is also metabolized by alcohol dehydrogenase, and therefore it will slow down the metabolism of methanol into formic acid. Our next cause of anion gap metabolic acidosis is ethylene glycol, and I discussed this one right after methanol because ethylene glycol is found in a lot of the same places as methanol. You can find ethylene glycol in antifreeze, industrial cleaners, and windshield wiper fluid just like you can methanol. Ethylene glycol is metabolized into the acids glycolate and oxalate. I've shown this at the bottom of the screen. It is metabolized by alcohol dehydrogenase just like methanol, and we'll talk in a minute about how some of the same treatments that inhibit alcohol dehydrogenase for methanol can be used in treatment of ethylene glycol. After metabolism by alcohol dehydrogenase, it goes on to become glycolate, which is glycolic acid, or oxalate, which is oxalic acid, and these are the acids that cause the anion gap to increase. Both of these metabolites of ethylene glycol are kidney toxins. Glycolate is toxic to the renal tubules, and oxalate can precipitate as calcium oxalate crystals and plug up the kidneys. So the main adverse effect you're going to see of ethylene glycol is kidney poisoning, in contrast to methanol, which has CNS poisoning and visual effects like we discussed. So the classic scenario is going to be a patient with a suspected ingestion. Maybe it was accidental, maybe it was a suicide attempt, maybe it is an alcoholic looking for another source of alcohol. In this case, in contrast to methanol, the patient will present with flank pain, oliguria, and anorexia. These are all symptoms of acute renal failure, and then there will be a high anion gap metabolic acidosis. And the treatment of ethylene glycol poisoning is the same as for methanol. These are treatments aimed at inhibiting alcohol dehydrogenase. This includes fomepizole and ethanol, just like we talked about before for methanol. Our next cause of anion gap metabolic acidosis is propylene glycol. This is also a solvent like methanol and ethylene glycol, but it's really only found in one main place. That's in antifreeze, and it's found in antifreeze because it lowers the freezing point of water. It's also used as a solvent for intravenous benzodiazepines, and this is one place you can find case reports in the literature where patients have sometimes developed propylene glycol poisoning if they were administered too high a dosage of IV benzodiazepines. The reason this causes an anion gap metabolic acidosis is because it's metabolized to pyruvic acid, acetic acid, and lactic acid. I've shown all their structures on the screen here. All of these are acids which will cause an acidosis and increase the anion gap. The main clinical feature of propylene glycol poisoning is CNS depression and coma. The patient will have a high anion gap metabolic acidosis from lactate and the other acids. And then there are many other adverse effects of propylene glycol you can read about. Hemolysis can occur, seizure, coma, and multi-organ system failure can occur. But the way you're going to recognize this as the cause of an anion gap metabolic acidosis in a board question, as opposed to methanol or ethylene glycol, is that there are usually no visual symptoms or nephrotoxicity like we see with those other poisons and causes of anion gap metabolic acidosis. Let me make an aside here and mention isopropyl alcohol. Isopropyl alcohol is also called rubbing alcohol. You've probably seen it in pharmacies. If you've ever used it as a disinfectant, it has a very strong odor. It's also found in many industrial products, and if you ingest isopropyl alcohol, it has effects similar to ethanol. So a key clinical scenario for a board question of a patient who may have ingested this substance would be an alcoholic who is trying to find sources of ethanol. It's less toxic than methanol or ethylene glycol, and it does not cause an anion gap metabolic acidosis. So why am I mentioning here? Well, I'm doing this because sometimes this is brought up in a board question to trick you. If they describe a patient who has consumed an industrial solvent but does not have an anion gap metabolic acidosis, they may be talking about a patient who has consumed isopropyl alcohol. The absence of a high anion gap acidosis is what suggests that a patient has consumed this. There's no role for fomepizole or ethanol to inhibit the metabolism of this substance. And finally, the main symptom of ingestion is coma, so it can look a lot like someone who has ingested some other substance, but there will not be an anion gap metabolic acidosis. All right, so that's it for the industrial solvents. Now let's move on to other causes of a high anion gap metabolic acidosis. The first one we'll discuss is uremia. So in advanced kidney disease, patients can develop a high anion gap metabolic acidosis. And the key word here is advanced, because you don't get an anion gap metabolic acidosis in patients with early or mild kidney disease. In those situations, early kidney disease leads to a non-anion gap acidosis. That's because the tubules aren't functioning normally and there's a reduction in acid excretion. But if the kidney disease becomes advanced and leads to uremia, which is high levels of urea in the plasma, then you can get an anion gap metabolic acidosis. And that's because the kidneys can't do their job of excreting organic acids. Things like phosphates, sulfates, urate, and others. All of these things will build up in the plasma and cause an increased anion gap metabolic acidosis. Our next cause of high anion gap metabolic acidosis is diabetic ketoacidosis, also called DKA. I talk about this extensively in the endocrinology section in the video on diabetes and also in the biochemistry section when talking about glucose. DKA usually occurs in type 1 diabetics. It usually occurs when insulin requirements rise but cannot be met because the patient has diabetes. For example, a classic trigger of DKA is an infection. During the setting of infection, you need more insulin effects, and if your body can't make insulin to meet that demand, DKA can develop. In DKA, fatty acid metabolism leads to the development of ketone bodies, and the ketone bodies beta-hydroxybutyrate and acidoacetate. Their structures are shown on the screen here. Both of these are acids which can cause an acidosis and also increase the anion gap. So the classic presentation of DKA, which again I talk about in other videos, is polyuria and polydipsia. This is because hyperglycemia occurs due to lack of insulin effects, and that leads to an osmotic diuresis. Patients classically have abdominal pain, nausea, and vomiting. Kussmaul respirations are deep, rapid breathing. This is caused from acidosis. The body is trying to compensate by overventilating the lungs and lowering the CO2. Kussmaul respirations can happen in any acidosis, but they're classic in DKA. And then finally, laboratory testing shows a high anion gap metabolic acidosis from ketones. Lactic acidosis is a classic cause of a high anion gap metabolic acidosis, and this is the one that you are most likely to see on clinical rotations. Lactic acidosis occurs anytime there is low oxygen delivery to tissues. When this happens, cells switch from aerobic metabolism to anaerobic metabolism, and pyruvate is converted into lactate. This is the structure of lactic acid or lactate on the screen here. It is an acid, and when the level gets high enough, it will cause a lactic acidosis. The pH will fall, and the anion gap will go up, causing an anion gap metabolic acidosis. So what are some clinical scenarios where there is low tissue oxygen delivery where lactic acidosis might occur? Well, first of all, in any form of shock, there's underperfusion of tissues, and this can lead to lactic acidosis. Ischemic bowel is a classic cause. In fact, in patients with belly pain, a lactate level is often checked because if it's high, it suggests ischemic bowel. Metformin therapy can lead to lactic acidosis, especially in patients with renal failure. This is a rare but feared complication of metformin therapy, and I talk about this in more detail in the endocrinology videos on treatment of diabetes. And then finally, when patients have seizures, they contract their muscles over and over again, and this often leads to a demand for oxygen that exceeds the supply, and that can cause a lactic acidosis. Ingestion of iron can lead to a high anion gap metabolic acidosis. This is seen in patients who have acute iron poisoning. So the clinical features of iron poisoning are divided into phases, and the initial phase after iron poisoning, the first 6 hours or so, is called the gastrointestinal phase. And it's called this because iron is toxic to GI mucosal cells, and this will lead to abdominal pain. And I've bolded abdominal pain because this is a classic feature of iron poisoning. Patients with iron poisoning in real life are rare, but when they do come in, they're sometimes misdiagnosed as having gastroenteritis because of the abdominal pain. And if you remember that iron is toxic to GI mucosal cells and causes abdominal pain, you can answer board questions about what the potential long-term outcomes will be from iron poisoning. That's going to be bowel obstruction. Patients with severe iron poisoning can develop a bowel obstruction from scarring weeks later after the ingestion of iron, and that's because there is scar tissue that is formed where the GI mucosal cells have been damaged in the intestines. So the first 6 hours after acute iron poisoning is the gastrointestinal phase, but later, about 24 hours after iron ingestion, patients can have damage to multiple different systems that can be life-threatening. First of all, they can develop shock if they've had a large enough quantity of iron consumed. Coagulopathy can occur because iron inhibits thrombin formation and action. The liver can start to fail, and this can worsen the coagulopathy, and the lungs can become damaged. Acute lung injury can develop, which leads to respiratory acidosis. So what you want to remember about iron poisoning is that initially it is dominated by GI symptoms, but later it's dominated by shock, coagulopathy, and respiratory failure if the iron poisoning is severe enough. And during this later phase, patients will develop an anion gap metabolic acidosis. That's because there are ferric ions in iron. These are molecules of Fe3+, and if you look at the bottom of the screen, Fe3++ plus water will yield 3 protons. So this can really raise the amount of protons in solution in the plasma and therefore causes severe anion gap metabolic acidosis. In addition, patients who develop shock from iron poisoning will underperfuse their tissues, and this can lead to a lactic acidosis. Isoniazid, or INH, is a tuberculosis antibiotic, and it's classically considered one of the mud piles causes of high anion gap metabolic acidosis, even though metabolic acidosis from this drug is very, very rare. If patients overdose on isoniazid, this can lead to seizures, and often these seizures are severe and refractory. It's called status epilepticus. So when this happens, just like I told you before, the seizures cause repeated muscle contractions, which can occur to the point that the demand for oxygen outstrips the supply. This will cause a switch to aerobic metabolism and cause a lactic acidosis. So basically, isoniazid overdose is one way of getting a lactic acidosis, which would be a high anion gap metabolic acidosis. Our last cause of anion gap metabolic acidosis is an aspirin overdose. The S in the mud piles mnemonic stands for salicylates. Salicylates are compounds that resemble salicylic acid. Aspirin is a salicylate. Its technical name is acetylsalicylic acid. This is its structure shown on the screen here. And in terms of medicine, when people say salicylates, they're usually talking about aspirin. So an aspirin overdose causes 2 acid-base disorders. Shortly after ingestion, the patient develops a respiratory alkalosis. This happens because salicylates have a direct stimulatory effect on the respiratory center in the medulla. This leads to hyperventilation, which lowers the carbon dioxide level and causes a respiratory alkalosis. A few hours later, the patient will develop a second acid-base disorder, and that disorder is a high anion gap metabolic acidosis. This happens because salicylates uncouple oxidative phosphorylation. This leads to accumulation of pyruvate, lactate, and keto acids, and all of these things cause a high anion gap metabolic acidosis. Because aspirin overdose causes 2 acid-base disorders, the laboratory findings can be tricky, so let's talk about those now. The pH is variable, and that's because it's a mixed disorder. So depending on what dominates, the alkalosis or the acidosis, the patient could be acidotic, alkalotic, or even have a normal pH. The PCO2 should be low because patients with an aspirin overdose hyperventilate, and the bicarb should be low because of the acidosis. But the key thing here is that when a patient has an aspirin overdose, if you use Winner's formula to check the carbon dioxide level, Winner's formula will predict a carbon dioxide level that is higher than the actual level. In other words, the carbon dioxide level will be lower than what Winner's formula says is expected for normal respiratory compensation. So this will make a lot more sense if we just go through a sample case. So here's a patient with a pH of 736, a carbon dioxide of 20, and a bicarb of 11. So the pH is below the normal range very slightly. 7.37 is the bottom of the normal range. So this is an acidosis. And the bicarb is low, so it's a metabolic acidosis. And the CO2 is also low, which could be normal respiratory compensation, but it's not because this is an aspirin overdose. And the way we figure that out is by using Winter's formula. So Winter's formula tells you the expected CO2 for metabolic acidosis. And Winter's formula says the expected CO2 is 1.5 times the bicarb plus 8 plus or minus 2. So if we take our value of 11 for the bicarb, Winter's formula says the expected PCO2 is 1.5 times 11 plus 8 plus or minus 2, which is 25 plus or minus 2. And this is much higher than our actual CO2 of 20. This means the CO2 is too low. It's lower than expected, and the disorder that causes CO2 to be too low is a respiratory alkalosis. So in a board question on aspirin overdose, they may describe a patient who ingested an unknown substance. And the way you're going to know it's an aspirin overdose is by applying Winter's formula and identifying that it's a mixed disorder of an anion gap metabolic acidosis with a concomitant respiratory alkalosis. So now we've gone through all the causes of metabolic acidosis, and I'll finish this video by going through a couple of odds and ends related to metabolic acidosis disorders. And the first one is hyperventilation. For any metabolic acidosis, the respiratory compensation is to increase the respiratory rate and cause hyperventilation. This will lower the PCO2, which increases the pH back towards normal. If we look at the bottom of the screen, in a metabolic acidosis, the serum bicarbonate level is going to fall. That will lower the pH. And by hyperventilating, the lungs will lower the PCO2 level, which will bring the pH back up towards normal. So remember this, in any board question about a metabolic acidosis, if they start asking you about the lungs, there's going to be an increase in the respiratory rate and hyperventilation. I mentioned this earlier when talking about aspirin overdose, but you should use Winter's formula in any metabolic acidosis to check whether or not there is a mixed compensation. In an acidosis, there is a compensatory respiratory alkalosis. We just talked about this. It's a fall in the PCO2 level from hyperventilation. Winter's formula will give you the expected change in PCO2. If the patient's actual CO2 does not equal the expected, then you have a mixed disorder. So just like we did in that sample for aspirin overdose, you want to check Winter's formula for any case of a metabolic acidosis. If the CO2 does not match the expected, then you have a secondary respiratory disorder. In addition to Winter's formula, there is another formula that can be used to look for a second acid-base disorder together with the metabolic acidosis. And that formula is the formula for calculating the delta-delta, which is also known as the delta ratio. The idea behind the delta-delta is that the change in anion gap in an anion gap metabolic acidosis should be similar to the change in bicarbonate. So for example, a normal anion gap is 12. If the anion gap rises to 20 in an anion gap metabolic acidosis, that's a change of 8. Well, if the only acid-base disorder present is an anion gap metabolic acidosis, then the decrease in bicarb should also be 8. If it's not, it indicates there's a second acid-base disorder going on. So you can calculate the ratio of the change in anion gap to the change in bicarb, this is called the delta-delta, to assess for a secondary acid-base disorder, and you only use this in the setting of high anion gap metabolic acidosis. You don't use it in any other acid-base disorder. And just as contrast, Winter's formula can be used for any metabolic acidosis to tell you the expected PCO2. In the case of the delta-delta, you only use it in the setting of a high anion gap metabolic acidosis. So as I said, the delta-delta is the ratio of the change in anion gap to change in bicarb. A delta-delta of 1 to 2 is normal. If it's less than 1, it means the bicarbonate level for that patient is too low. So there must be something going on to make the bicarbonate lower than it should be, and that something has to be another metabolic acidosis, meaning a non-anion gap metabolic acidosis. If the delta-delta is greater than 2, it means the bicarbonate level for that patient is too high. There's two reasons this can occur. The first one is that there's a secondary metabolic alkalosis occurring because metabolic alkaloses raise the bicarbonate level and therefore could make it too high. The other possibility is that that patient has a pre-existing chronic respiratory acidosis. So patients with COPD always have a high level of CO2. They have a chronic respiratory acidosis. Over time, the kidneys make lots of bicarbonate to compensate for the chronically elevated level of CO2. So patients with COPD always have a high bicarbonate level even when they're just walking around. So if one of these patients develops an anion gap metabolic acidosis, that patient is going to have a bicarbonate level that's higher than expected, and that will lead to an abnormally high delta-delta. So I'll go through an example just to make this clear. It's very unlikely you'll be asked to calculate a delta-delta on step 1, but you should know what it's used for because you are often asked to recognize mixed disorders. So let's imagine a patient has a pH of 7.21, that's an acidosis. The bicarb is low, so it's a metabolic acidosis. If the sodium is 150 and the chloride is 96, you can do the math and the anion gap is 42, which is elevated. So this patient has a high anion gap metabolic acidosis. The change in the anion gap is the patient's anion gap minus 12, which is a normal gap, and that's 30. The change in bicarb is a normal bicarb, which is 24, minus the patient's bicarb of 12, and that's 12. If we calculate the delta-delta, it's 30 over 12, or 2.5. This is high. This means that this patient's bicarb level of 12 is too high. So there must be some reason for that, and there are two possibilities. One is a concurrent metabolic alkalosis. The other, as I told you on the last slide, is a prior chronic compensated respiratory acidosis. And then the final topic for this video is a low anion gap. So a normal anion gap, as I told you before, is around 12, and that's what's shown in the middle of the screen. There are two situations where the anion gap can be low. Those two situations are hypoalbuminemia and multiple myeloma. We'll do hypoalbuminemia first. That's shown on the bottom left side of the screen. Remember that albumin is a major component of the anion gap. So if there is a low albumin level, for example in a patient with liver disease, the anion gap will get small and be lower than normal. What happens in multiple myeloma is that often IgG antibodies are produced and they are cationic, they are positive. So they are going to push sodium ions, which are also positive, out of the plasma. This is going to lower the measured amount of sodium. So if you look at the bottom right side of the screen, this patient has some positive IgG, which has lowered the sodium level. Therefore, even though the anion gap is technically normal, meaning the substances that make up the gap are of normal levels, We're going to calculate a low gap because the sodium level has been slightly lowered by IgG. So key point, and it's high yield for your boards to know that patients who have a very low anion gap often have either low albumin levels or they have multiple myeloma. And that concludes our video on metabolic acidosis.